Good morning, everyone. So I think it's almost 8 o'clock, so I'd like to open the first session of the day. Clinical Trials Spotlight is the session in this room, so just for those who haven't really checked the program. My name is Robin Ali from University College London, and my co-chair is Dr. Onodera from the National Centre for Child Health and Development in Tokyo. So this morning we have just 3 talks rather than the usual 4 in this session. So we need to, just to remind all the speakers, we need to finish on time and to keep to schedule. So even though the session's normally a 2-hour slot, it will finish at the talks will finish at 9:30. So if the speakers could keep to their 25-minute allocation, and we'll sort of signal towards the end so that you can wrap up. So there's time for a few questions. And the first talk of the morning, there's been a change of speaker. Unfortunately, Brian Sorrentino couldn't make it today, but his colleague Morton Cowan from UCSF is going to present on behalf of the group. And so Mort Cowan is going to talk about their X-SCID clinical trial. So please come up. Thank you very much.
Thank you. So I know Brian really wanted to be here today, but he couldn't make it. And so he asked me to present on behalf of all of our collaborators at St. Jude Children's Research Hospital, at UCSF Benioff Children's, and at NIH NIAID. So these are my financial disclosures. I have no conflicts of interest. So I wanted to talk just briefly, give you some background on severe combined immunodeficiency disease, and then a little bit about outcomes with allogeneic transplant. Certainly SCID is considered the most severe primary immune deficiency. These patients have no T or B cell function, and they may or may not have NK cells as well. It can be inherited as an X-linked form, which we'll focus on today, or autosomal recessive or spontaneous. There's probably 15 to 18 different genes that mutations in which result in the SCID phenotype. These patients present very early in life, within the first 6 months of age. At least that's the classic form, with infection, failure to thrive, skin rashes, thrush, diarrhea, cough, and a variety of opportunistic infections. There are SCID variants, including reticular dysgenesis, leaky SCID, and Omen syndrome, but I won't go into those for the sake of time. Newborn screening is now available in the United States, and we're probably screening for more than 95% of all newborns. That means that these babies are being diagnosed prior to a month of age, and they're mostly infection-free and pretty healthy. We found from newborn screening studies that the incidence is about 1 in 58 to 1 in 60,000 live births, and without either an allogeneic hematopoietic cell transplant or enzyme replacement therapy or autologous gene therapy, these patients die. X-linked severe combined immunodeficiency is the most common form of SCID and represents about 25% of all SCID diagnoses. It's a result of the mutation in the IL-2RG gene, which codes for the common gamma chain receptor for 6 different cytokines. This results in absence of T cells and NK cells, but the presence of B cells, except that they're non-functioning. And this gives you the T minus, B plus, NK minus phenotype. And without definitive therapy, like an allogeneic transplant or gene therapy, these patients will die in the first year of life. This just is a figure that shows you the 6 cytokine receptors and where the common gamma chain is critical for each of them, and then how they're all involved in T cell, B cell, or NK cell development or function in one way or another. So just one slide on results of allogeneic transplant for SCID. And this is the study that was done by the Primary Immune Deficiency Treatment Consortium that represents 45 centers in the US and Canada focused on primary immune deficiencies. And this was a study that involved 240 patients with SCID who were treated with an allogeneic transplant between 2000 and 2009. And you can see here that if they had a matched sibling donor, outcome was really quite good, better than 95% surviving out to 10 years. However, if they had an alternative donor, which could have been a matched other related donor, a mismatched related donor, or an adult unrelated donor or cord blood, then the survival was not as good. It's not terrible, but it dropped significantly. If these patients were infected at the time of their transplant, again, matched sibling donors better than 90% survival, but there was a significant drop in the alternative donors between 40 and 50% survival. So the issues, there are 4 main issues in terms of using alternative allogeneic donors for transplant for X-SCID. Well, one is that some of these patients actually have NK cells, especially if they're a little leaky in their mutation. And these patients will reject or have a significant risk of rejecting their donor graft. Also, less than 10% of these patients will achieve B-cell reconstitution. So they get T-cell immunity, but not B-cell immunity, unless they receive high-dose chemotherapy. And just for a frame of reference, I put in here the most common drug used is busulfan, which is an alkylating agent. And if the dosing that results in a cumulative area under the curve of between 70 to 80 milligrams .hour per liter is typically what is given in terms of this type of chemotherapy for allogeneic transplant. And this will result in about 80 to 90% achieving B-cell reconstitution. And then graft versus host disease is a major complication of allogeneic transplant. It has a significant morbidity and mortality associated with it. And in this study, 28% developed acute GVHD and 15% chronic GVHD. And then finally, we found that with certain types of alternative donor transplants, T-cell immunity may decrease over time. So we think that with autologous gene therapy, rejection and GVHD will be eliminated since these are the patient's own cells. And then in terms of B-cell reconstitution and this decrease in T-cell immunity, giving a low-dose exposure busulfan, we also think we'll be able to overcome those 2 issues. So this is just a brief summary of what gene therapy for X-SCID has been going on to date. In the late 1990s, early 2000, the initial study that was done in Europe involved a gamma retroviral vector. It did not use any conditioning that was given, and what was found in those initial patients was that there was good T-cell immune reconstitution, but no B-cell immunity, and all these patients remained on gamma globulin replacement therapy. However, the big issue with this retroviral vector was insertional mutagenesis, and 30% of the initial 20 patients developed leukemia. The second generation vector was a self-inactivating gamma retroviral vector, again without conditioning, and also again T-cell immunity was restored, but not B-cell immunity. However, at least with up to 7 years of follow-up, there's been no evidence of clonal dominance or insertional mutagenesis. And then finally, the vector that we're using in our study was developed. It's a self-inactivating lentiviral vector. And this study that is ongoing now at NIH uses non-myeloablative busulfan conditioning. And the first 8 patients that have been treated, they were all patients who had failed an allogeneic haplocompatible transplant. So they were older patients who had previously been treated, had some T-cell immune reconstitution so they could survive, had no B-cell immune reconstitution, and many were quite symptomatic with chronic infections, chronic lung disease, and so forth. What this study has shown is that there's been very good marking, multilineage marking in T cells, B cells, NK cells, and myeloid cells with correction of T cell immunity, and in some patients now being able to come off of immunoglobulin replacement therapy. There's been no evidence of insertional mutagenesis with up to 5 years or more of follow-up, so this is very encouraging. So this vector, which we're also using in the study that I'm going to tell you about now, was developed at St. Jude in collaboration with Dr. Harry Malik at the National Institutes of Allergy and Infectious Disease at NIH. It's a self-inactivating lentiviral vector. It has insulators in it. It uses an EF1 alpha short promoter and a codon-optimized human IL-2RG cDNA that codes for the common gamma chain receptor. Preclinical efficacy and safety studies in terms of oncogene activation have been published, and the vector is produced using a stable lentivirus producer cell line at St. Jude. So this is a schema of the clinical trial. So the patients, once they're determined to be eligible for the trial, undergo a bone marrow harvest. The CD34 positive cells are isolated and then transduced with the lentiviral vector over a 3-day culture period. The cells are then cryopreserved in liquid nitrogen, and once the release criteria are met, the patient undergoes 2 days of busulfan administration using a pharmacokinetic model that was specifically developed for infants under a year of age. Once they've received the busulfan, the cells are thawed and infused into the patient. These are the characteristics of the first 8 patients that have been enrolled in the study. You can see that the age ranges from as young as 2 months of age to as old as 11. In part, this is due to the fact that these patients were diagnosed either by symptoms somewhat later after birth or by family history or newborn screening. And those are the younger patients that were treated. There were 3 of the 8 patients that had a maternal engraftment, and you can see patient 1 actually had substantial maternal engraftment at the time of diagnosis and treatment. And there's a variety of medical problems. The main medical problems were infectious, and these were primarily, the most serious ones were in the patients diagnosed by symptoms. So you can see cytomegalovirus, coronavirus, disseminated BCG, and Legionella were significant problems in those patients. The patients diagnosed by newborn screening were by and large healthy, and even the rhinoviruses were detected just by screening as opposed to by symptoms. The CD34 cell dose that these patients received varied from a low of 4.46 in patient 1 to as high as 15.1 million cells per kilo. The vector copy number in the graft also varied from a low of 0.16, again in patient 1, to as high as 1.13. This just shows the busulfan pharmacokinetics. We're targeting a level, busulfan level of a cumulative AUC of 22. This is about 25% of what the ablative dose would be, typically be used in patients receiving an allogeneic transplant. The important thing I just want to focus on is that the total dose in milligrams per kilo that these patients received varied considerably from a low of 2.59 up to 5.67. And this is to be expected because of the varied clearance that these patients have, especially those under 12 months of age. However, if you look at the total AUC that was achieved, the cumulative AUC, it only varied between 20 and 23. And in fact, all of the patients were within 10% of the targeted 22 that we were trying to achieve. There were no adverse events that were significant in these patients. None of the patients required a transfusion during the as a result of the busulfan administration. You can see the drop in the neutrophil count and the rapid recovery, and also the drop in the platelet count, but also recovery. In terms of gene marking in the lymphocyte subsets, you can see a very rapid rise in gene marking in the vector copy number in T cells, beginning between 1 and 2 months post-infusion, and then sort of leveling off between 4 to 6 months. Same thing is true for marking in B cells, which is again substantial, and marking in natural killer cells, also substantial. The one exception is patient 1, who got the lowest cell dose and the graft with the lowest vector copy number. And I'll talk more about that patient in just a minute. But although that patient did have reasonably good marking in natural killer cells. And then all of these patients, as part of the protocol, undergo a bone marrow aspirate at 4 months and at 12 months, and this just shows the vector copy, or the marking in sorted CD34 cells, colony-forming units, and CD19 cells. And you can see that it actually tends to maybe improve a little bit over by 12 months, but it's very good marking in these bone marrow cells. The marking in the monocytes is a little bit more variable, but again, maybe except for patient number 1, the marking is quite good in monocyte. This is in blood monocytes. And then in terms of immune reconstitution, you can see in all the patients except for patient 1, there's a rapid rise in T cell numbers beginning between around 3 to 4 months, and certainly by 6 months post-infusion. Same thing is true for the naive subset of T cells, which goes up uniformly in all of the patients except patient 1. And then somewhat more variable increase in NK cells over time, but patients definitely are also getting NK cells. Thymopoiesis, as measured or reflected by TREC formation, you can see that prior to treatment it's very low. In fact, that's how many of these patients are diagnosed now by newborn screening. And then again, by 4 to 6 months, it's risen quite nicely. Functionally, by 4 months post-transplant, all of the patients, except for patient 1, they have a normal lymphocyte proliferative response to phytohemagglutinin, and the T cell receptor diversity is entirely normal in the 4 patients shown here. In terms of B cell reconstitution, we only have immunization data on patient 2 so far, and it's quite good with respect to response to pneumococcal polysaccharide, as well as tetanus, diphtheria, and pertussis. And this just shows the rise in the IgM levels in these patients as well. So patient 1 had a very poor recovery of T cells over the first 12 months post-transplant. And We might have sat this out a little bit longer, but for the fact that this patient had persistent cytomegalovirus infection in spite of optimal anti-CMV treatment. You can see this is in logs of a pretty high CMV load. So we did give him a boost of gene-transduced autologous cells without any more chemotherapy. So he didn't get any additional chemotherapy. He just got the boost. And within 2 to 3 months, there was a rapid rise in the CD3 count. And again, quite nicely, he cleared the CMV infection. You can see also the marking of this is the NK cells, which were already being marked, but also the rise in marking in the T cells. Still no rise in marking in B cells, although maybe because we didn't give him any more chemotherapy, that might be expected. And this just shows the vector integration site distribution in 5 of the patients. And basically, here in these colored bars here are the top 20 insertion sites. You can see that it's really by and large polyclonal with no dominance developing so far. Clinical outcome shows the age of the patient currently as well as the follow-up in months post-infusion. And the patient 1, as I said, showed you cleared the CMV, cleared the coronavirus. He did develop autoimmune hemolytic anemia after the boost, so we probably did something to his B-cell immunity as well as his T cells. However, this did resolve with treatment and hasn't been a problem since. The other patients cleared their other infections, the BCG, Legionella, and everybody is basically doing well. The second patient, as I showed you, has been immunized off IVIG. The third patient is off IVIG now and will be starting immunizations next week. So in conclusion, this SCID lentiviral vector, along with targeted low-dose busulfan exposure, is well tolerated. It's resulting in transduction and engraftment of long-term of CD34 positive cells. We're seeing new thymic emigrants and a broad T-cell receptor repertoire. There's a pretty high level of B-cell and NK cell marking, and we're seeing good reconstitution of T-cell and a developing reconstitution of B-cell and NK cells. We're not seeing any evidence to suggest insertional mutagenesis. There is this potential risk of autoimmune hemolytic anemia that we'll have to follow longer. Boosting with transduced stem cells may be something that we can consider in the future if we have other patients that have delayed recovery. And of course, we need a larger cohort and longer follow-up to determine safety and sustained efficacy. And this is pictures are worth 1,000 words, and we have some very happy little guys here. And again, have to acknowledge the patients and families. Brian Sorrentino, who's really led this group, and without whom I don't think I'd be standing here, we'd be presenting any data. And then all the other people involved. I won't go through naming names, and certainly the referring physicians and the funding sources at NIH, the Heart, Lung, and Blood Institute, California Institute of Regenerative Medicine, and the Assisi Foundation. Thank you.
Thank you very much. So thanks for keeping to time. There is also time for 1 or 2 questions. If you could go up to the microphone. Whilst they're going up, could I ask Mort, so it was interesting that you could boost by a second administration. How many times do you think that will be sort of possible to boost, and how long can you store transfused cells for? And
I think that, I mean, the cells we can, sorry, I'm glad I made it to the end. The cells I think we can store for quite some time. I mean, sort of set the shelf life at 5 years, but I think they're good longer. I don't know how much. I mean, boosting with allogeneic transplants has been kind of quite variable. We were pretty impressed by the response with these autologous cells, but
And how many batches, how many cells do you have? Do you have enough to do?
well, I mean, that's that's another issue. In this case, there were cells that were stored, so we didn't have to go back and collect any. The problem with boosting in most of the cases is that, number one, we don't store extra cells typically. We try to give as many as we can. And also, you've now treated the patient with busulfan. So if you try to harvest more cells, they have been chemotherapy exposed. So it would raise some questions for sure. It's a good question.
Given these data, do you think there's a minimal number of cells or a minimal vector copy number you would recommend, for a future study that you would need to use to get a good response?
Yeah, that's an excellent point. And I think obviously we need more data, but it does suggest, if you look at the results, the recovery of the kinetics of recovery and the intensity of the recovery, it does seem better in those patients who got either sort of more cells and a higher vector copy number in the graft. So I think one of the goals that we have is trying to optimize the vector copy number and try to make it more consistent. And I think that will improve the outcome.
I had a similar question. In fact, based on integration sites, have you assessed the number of long-term repopulating cells genetically modified you have in those patients?
I'm sorry, I didn't get...
Based on the integration sites, have you assessed the number of long-term repopulating cells containing the vector present in the patients? Based on the number of sites and present in the different lineages?
I'm not sure I understood the question, but in terms of the integration sites, like we have looked across the different lineages, and we can see common integration sites. I don't know if that's what you were...
Yeah, so how many per patient?
Can you speak up a little bit?
Yeah, how many per patient in this case? How many long-term repopulating stem cells?
How many sites?
How many long-term repopulating stem cells containing the vector have you assessed per patient? It is, 1,000.
I'm really sorry, I couldn't get the question.
No, the question was just how many long-term repopulating stem cells containing the vector have you assessed based on the number of negation sites in the different lineages? But yeah, I think you mentioned it.
Maybe we can talk afterwards. Sorry.
So another question in French. So you used busulfan for this study, busulfan or generic busulfan. And the other question, because do you use the daily PK or because it seems to be very difficult for some sites to do a daily PK, to get the AUC. So we'll talk about this later.
I'm afraid the French accents are defeating us. I'm really sorry. Perhaps we can have a discussion afterwards. I'm really sorry. Yeah.
Just one question. If my memory correct, so one patient has a maternal T cell. In that case, is there any difference or in some influence on a transducer or clinical symptom such a patient?
Yeah, I mean, we were concerned that maybe with the maternal cells it would be more difficult, but we haven't seen any real differences in terms of outcome.
Yeah, I mean, so if there is some maternal T cell in that case, so we need some fludarabine or something like that.
Well, we thought about that, either using an anti-T cell antibody or fludarabine, but we decided to keep it clean. And again, it hasn't been an issue.
Thank you very much. Thank you.